Latam.
Latam. Then MLTC.
And then we have GCPS, NIHR, and our esteemed national stakeholders who are honoring this gathering are also here. All right. Thank you all so much for joining us.
Okay. Great. So we would like to start with a prayer as custom demands in Ghana. So I would kindly invite Dr. NIHR to give us a prayer with a round of applause.
Shall we pray? Father, in the name of Jesus, we thank you for today. We thank you for our lives. We thank you for this gathering aimed at discussing the progress and sustainability of global health research centers that seek to improve the care for and mitigate against these common conditions that affect people worldwide. It's our prayer that every discussion, every activity here will inure to the benefit of all mankind. Take charge, take preeminence of this gathering, and at the end, glory and honor shall be given to your holy name. Thank you in Jesus' name. Amen.
Amen. Thank you very much, Dr. NIHR. So we'll also move on to a welcome address by the institution that is hosting us. That's the Ghana College of Physicians. So we are inviting the rector. But before that, I would give a short bio on him. So Professor Richard K.A. M.K. Adanu, that's the rector of the Ghana College of Physicians and Surgeons. He's a specialist obstetrician, gynecologist, and a woman reproductive health epidemiologist with fellowships from the Ghana College of Physicians and the West African College of Surgeons and American College of Obstetricians and Gynecologists. Professor Adanu trained at the University of Ghana Medical School and completed his postgraduate training at the Kolebo Teaching Hospital. He also holds a Master of Public Health from the Johns Hopkins Bloomberg School of Public Health, where he was a Gates Scholar and a member of the Delta Omega Honor Society. With decades of experience, his work has significantly advanced maternal health, family planning, and cervical cancer prevention. He was previously the Dean of the University of Ghana School of Public Health and has published extensively and is contributing to both clinical practice and public health research globally. We are truly honored to have him welcome us. Can you please welcome him with a round of applause? Thank you.
Good morning to all of you. And it's a joy to have the centers all come to Accra for this meeting. I think about 3 years ago, we got information from the National Institute of Health and Care Research UK that the West African Consortium led by Professor Irene Ajapong of the Ghana College of Physicians and Surgeons had been awarded the grant to do some research into non-communicable diseases in Ghana, and we're very excited about that. Then I was told about, I think the first global meeting was in Southeast Asia also. We heard about that. Then there was the meeting in the UK last year. And I said to myself that these guys are picking the wrong places to go to. Then Irene told me that they had met and they said they were coming to Ghana. I said, oh yes, now they've picked the right place to come to. So I'm very happy that all the centers are in the right place this year for your meeting. And without any attempt at offending our very celebratory colleagues from Latin America, where I think people would want to go next year. If they choose to come to Ghana again, I mean, just come. We'll be happy for you to be here. But then it's a great honor for the Ghana College of Physicians and Surgeons to host all of you here. So for the next 3 days, you're going to be here, and I'm sure that you're going to have a very enjoyable time. I mean, getting to know each other, and then also discussing the great things that you've been doing. And I would say, whilst we are here, sometimes it's all business, but then, and when I come to meetings like this, I tend to just, I mean, the introvert that I am, I tend to sit at one place and get my business done and move out. But I'll encourage you to all be like Khalid. Khalid from Pakistan, he walked up to me and we had a nice conversation. So don't be like me, be like Khalid. Get around and get to know a few other people, get to know what they do. And don't be as quiet as everybody else. Be a bit loud like the Latin Americans. I mean, when they were called, they really made some noise. So make some noise, let's have some fun, and let's enjoy this time. So once again, welcome to Ghana. Welcome to the Ghana College of Physicians and Surgeons, and have a great time over this next 3 days. Thank you.
Thank you very much, Professor Danu. Distinguished guests, it is my honor to introduce the chair of the program, Professor Kwaukumi. He is an eminent obstetrician, educator, and pioneer in global health. He is the founder and president of Family Health University College, comprising a medical school, nursing and midwifery school, and teaching hospital, co-established with his wife, making him the first to build this full continuum of health training and care in West Africa. He is a former head of obstetrics and gynecology at the University of Ghana, and he led his department to 8 consecutive Best Department Awards and has received numerous honors, including the Fellowship of the American College of Obstetricians and Gynecologists. His global impact includes groundbreaking surgical innovation and co-inventing the WHO-endorsed medical eligibility criteria wheel, now used worldwide. A prolific author and thought leader, his work continues to shape women's health and medical education across Africa and beyond. With a round of applause, let us welcome the chair of the program, Professor Kwaukumi.
Good morning, ladies and gentlemen. Director of the Ghana College of Physicians and Surgeons, the leadership of SHE University, representative from Foreign, Commonwealth and Development Office, Ghana, representative from the Department of Health and Social Care, and the National Institute of Health Care Research, NIHR, UK. Distinguished national and West Africa policymakers and decision makers present, distinguished researchers and partners from NIHR, Global Health Research, represent from Ghana, NCD Alliance, members of the press, ladies and gentlemen, good morning again. Before I start my remarks, I would want you all to be, as much as possible, look at your table and consume the water in front of you, and even more, so that we look at the weather and gain something from it. Again, I'll encourage you to be moving your limbs, your hands, your foot, all over during the symposium. So, ladies and gentlemen, it is my great pleasure and honor to welcome you all to the opening policy event of 2026 Global Health Research Cross-Country Symposium here in Accra, Ghana. Your presence here today shows the strength of global collaboration and our shared commitment to improving health outcomes across diverse settings. We are especially grateful to UK National Institute for Health and Care Research and the UK Department of Health and Social Care for their continued support and investment in global health research and for fostering equitable partnerships that place low and middle income countries at the center of research, leadership, and impact. Ladies and gentlemen, as we gather for this third cross-center symposium, we are presented with a valuable opportunity to reflect on our collective progress and to chart sustainable pathways for strengthening health systems and improving health outcomes. The theme for this year, ensuring sustainability from global health research centers, invites us to reflect on how we can sustain capacity, partnerships, community engagement, and interventions beyond the lifespan of individual projects. Over the next few hours and the next 3 days, we'll hear remarks from our founding partners, presentations from our 5 research centers, and a keynote address which will help frame our discussions within national and global health priorities. Ladies and gentlemen, I encourage all of us to participate actively, listen openly, and think strategically about how we can collectively ensure that the work we are going to do today continues to generate lasting impact into the future. It is my privilege to welcome you once again and to declare the event officially commenced. Thank you very much for your attention.
Thank you very much, Prof. I just realized that we didn't give some form of introduction and also some overview of, the program. This program is going to be kind of bilingual or even 3 languages. So we've provided receivers, and you find the receivers on your table. So in case you don't understand English, I think the channel 1 is for English, 2 for French, and then 3 for Spanish. Okay, thank you very much. So we would like to get some little discussions or talks from the founder or the founders. To do that, I would like to introduce the representative of the founder. In fact, the person representing the founder is also here in the capacity as a co-chair too. So she's in the person of Professor Kara Hansen. Professor Kara Hansen is a professor of health systems economics and dean of the Faculty of Public Health and Policy at the London School of Hygiene and Tropical Medicine. She also serves on the board of NIHR Strategy and Engagement Board, where she plays a key role in shaping global health research priorities and partnerships. With over 3 decades of experience, her work has significantly advanced health financing, strategic purchasing, and the engagement of the private sector in strengthening health systems, particularly across low and middle income countries. She currently serves as the president of the International Health Economics Association, which I'm also a health economist, underscoring her global leadership in health economics. Professor Hansen is also the director of Global Health Research Program. We are very honored to have her here. With a round of applause, can we kindly welcome her?
Thank you very much for that kind introduction, and good morning, ladies and gentlemen, distinguished guests, and may I suggest that all protocols are observed. So it's really nice to be here with so many friends, and I do feel like after a number of these encounters, we are developing across the centers a real sense of friendship and collaboration and companionship as we move together through these programs. And I hope that those of you who are visiting the program for today will quickly get a sense of that collaborative spirit and partnership that exists across this community of researchers. It'd be nice, I think, to just share a little bit about the global health research portfolio here in Ghana. So since the NIHR started funding global health research in 2016, the portfolio has awarded over £18 million in program funding to 30 different institutions in Ghana to undertake high-quality global health research. And alongside this, we've supported 20 projects through a range of other funding streams that are administered through our partnerships with other funders, and that includes EDCTP, the European and Developing Countries Clinical Trial Partnership. The centers holds a very special place in our portfolio. It is the most significant, largest kind of program investment that we've made, and you'll hear shortly from one of my colleagues about our expectations of the centers. But those of you who have attended our symposia over the last few years will know that each year I have one particular theme that I bang on about. So the first year, you'll remember that I said, we must be bigger than the sum of our parts. Right? So we have 5 awards, each one has multiple partnerships, but together we should be able to create knowledge and experience and expertise that goes beyond just the sum of the different centers' activities. And that should happen really through these events where we learn more, not just about the very high quality research that I know that you're all undertaking, but also how to do community engagement well, how to do equitable partnerships well, and how to do capacity strengthening well. And I think we're really well on our way on that journey. Last year, I was banging on about learning lessons across geographies. So clearly there's a huge scope for learning across all the settings where research is being undertaken in this group. But also we suggested that we might look at how the learnings from global health research might also influence the delivery of services in the global north. And and in particular thinking about how what we're learning about NCDs and about community engagement can influence how NCD research takes place in the NHS in England. And since our meeting last year, some of you will know that our Department of Health has launched its new 10-year strategy. And in that strategy, there are 3 shifts that they talk about. So one is from cure to prevention. One is from analog to digital. And the third is from hospital to community. So I hope your ears are all perking up there and thinking, well, we've been doing that for a long time. We have plenty of lessons that we can teach other parts of the world. And that was my message last year. But I think it's enhanced now by knowing a little bit more about how some of the challenges of health system organization and development in high-income countries can be well addressed by the research that's taking place in the global south. So this year, I'm going to bang on about impact. So you'll know that last year we had significant cuts in the international development budget. That has affected the budgets for global health research. And our mission should therefore be to demonstrate the value of investing in global health research. What are the impacts that generates? Clearly, on patients and the public by improving health services and improving health outcomes, but also impact in terms of the ways we do research and the ways that we engage our communities in research. So that's, at every moment, I'm going to be saying, and let's start planning our pathways to impact, because these things don't happen without effort. I know that you've all been working with research and policy colleagues through the entire life of your centers, that you'll continue to do so. But now, as you're getting ready to begin to have some important and interesting results, think about what those pathways to impact are going to look like. And I hope we'll have lots of chances to talk about those during the course of our 3 days together. So ladies and gentlemen, thank you very much for the opportunity to introduce the ambition of the NIHR to those of you who are visitors. And I hope we have a fantastic week together. I have very high hopes for us. Thank you.
Thank you very much, Co-Chair. Next, we have another keynote address by a representative from UK's Foreign, Commonwealth and Development Office, FCDO. She's in the person of Enyonam Azuma, and her work reflects FCDO's commitment to strengthening collaboration between the UK and Ghana. We are honored to have her with us and appreciate her contribution to advancing shared development goals. Shall we, with a round of applause, welcome our esteemed guest.
Thank you very much. Good morning. I would like to hear a more enthusiastic response. If the morning has been good to you, then I would like to hear a good response to good morning. Thank you very much. Distinguished colleagues, partners, researchers, and friends. And I would also like to stand on the existing protocols that have been set. It's a pleasure to welcome you to Accra for the 2026 NIHR Global Health Research Cross-Center Symposium. And as I was introduced, so I lead the Human Development team here in FCDO, which is part of the British High Commission in Ghana. Bringing together centers working on long-term conditions, multiple morbidities, mental health, environmental change, and non-communicable diseases is both timely and necessary, particularly for West Africa and other low and middle-income countries, where these challenges increasingly intersect. Effective policy implementation depends on strong, credible evidence. The work of NIHR Global Health Research Centers has shown how applied research can inform real decisions, whether improving hypertension detection and control, strengthening community-based NCD care, or generating policy-relevant insights on how environmental exposures and social conditions shape disease outcomes. The output of the NIHR Global Health Research Center for NCD control in West Africa, including policy briefs, health systems research, and community-engaged approaches, demonstrate how locally led research can influence practice and policy at national and regional levels. In Ghana, as the country advances reforms to strengthen primary health care and deliver universal health coverage through CHIPS, NHIS reforms, and the rollout of the free primary health care and the Ghana Medical Trust Fund, policymakers are increasingly asking what works, for whom, and at what cost. Research from NIHR Global Health Research Centers helps answer these questions. The NIHR Global Health Research Center for Non-Communicable Disease Control in West Africa therefore provides a powerful example. Its work on improving hypertension and diabetes detection, community-based NCD care, task shifting, and strengthening primary level service delivery has generated practical evidence that directly informs Ghana's and the wider region's efforts to integrate NCD care into primary health systems, rather than treating chronic diseases as a specialist or tertiary concern. This symposium rightly places emphasis on the connections, that is, between non-communicable diseases, long-term and multiple conditions, mental health, and environmental change. These are not separate policy problems. They compound each other, particularly for vulnerable populations, and demand integrated responses across health systems, urban planning, climate action, and social protection. In West Africa, rapid urbanization, air pollution, heat exposure, and changing food environments are increasing cardiometabolic risk, while mental health conditions remain underdiagnosed and undertreated, often alongside chronic physical illness. The research represented here helps move the conversation from siloed programs into integrated, person-centered care models that better reflect lived experiences. The UK places strong value on equitable UK Global South research partnerships. These collaborations are not one way. Insights from Ghana, the region, and other regions on multi-morbidity, community engagement, prevention, and health system resilience are increasingly relevant to high-income countries who are facing similar challenges from aging populations and global disease. Knowledge generated from here will inform policies in Ghana, not only in Accra, but also in London. I would like to particularly welcome NIHR's focus not only on knowledge generation, but on capacity strengthening, supporting researchers, institutions, communities, and policymakers to use evidence well. Building sustainable research and policy capacity in West Africa is one of the most enduring contributions we can make. The legacy of the NIHR centers in West Africa and globally will be measured not just in publications, but in improved research leadership, stronger policy uptake, and a more resilient health system. I therefore wish you a productive symposium, rich discussions, and continued collaboration that turns high-quality research into better policies and better health outcomes. I thank you very much for your attention and wish you all the best. Thank you.
Thank you very much. These were quite insightful words from the funders. In fact, one thing I realized was the impact that these fundings actually have. And we are some products of this impact. So both of us are actually doctoral researchers on the Stop NCD project. And it's as a result of these fundings, that's how can we have this type of capacity building. So can you kindly give them another round of applause? Thank you. So we are moving next to hear from the various centers. So we have 5 centers. I want to hear the research that they've been doing so far, the findings and its relevance, so we'll learn together. So in order to do that, we have a particular structure that we want to follow. So there are 5. I'm going to list them, and each of them would have about 5 minutes. And in between, at the end, we would have some questions or brief remarks. So the very first one is the NIHR Global Health Research Center for Community Management of Long-Term Conditions. Then the second would be the NIHR Global Health Research Center for Multiple Long-Term Conditions. Then the third presentation would be the NIHR Global Health Research Center for Improving Mental and Physical Health together, not singular, together. Then the fourth one is NIHR Global Health Research Center for NCDs and Environmental Change. And then the last one would be the NIHR Global Health Research Center for NCD in West Africa. So can we kindly welcome the representative from the very first center with a round of applause. That's the NIHR Global Health Research Center for Community Management of Long-Term Conditions.
So to save some time, we won't be coming back and forth. So as soon as they are done, you just, the next center just follows with their presentations. So please, I know we can get carried away because we are so passionate about our work. But when we say about 5 minutes, we mean 5 minutes or less. So please keep note of the time. If you see us walking slowly towards you, it means your time is almost up. Please welcome her with a round of applause.
Well,
That was a double act.
yeah. I'm Carlos Gomez Restrepo. I'm psychiatrist. And in Colombia, about 5 minutes is 7 minutes. Okay, so we will begin with this. I will change to Spanish because I want you to feel our difficulties over there between English, Spanish, and all the languages we have over there. So if you switch from Spanish to English, voy a empezar en español. Number 3, I think is number 3. Okay, here we have the presentation that is LATAM. El LATAM está acá la figura de los diferentes grupos que tenemos en las 3 poblaciones, en Bolivia, en Colombia y en Guatemala. Algo que es importante, the next one, please. El próximo es que tenemos que contemplar que en Bolivia hay 11 millones de habitantes, hay 36 lenguas, o sea, hay 36 grupos diferentes de indígenas y se estima que 4 millones de personas, 4.300.000 son indígenas, o sea, la mitad de la población. En Guatemala hay 18 millones de habitantes en todo el país, hay 22 lenguas y hay 10 millones de personas que se consideran indígenas o de tradición indígena. En Colombia hay 50 millones de habitantes, hay 110 grupos y hay 4 millones de personas que se consideran indígenas. Entonces, vamos por el estudio como tal. Es la colaboración regional entre 4 países, Inglaterra, en Queen Mary, con Vicky allá, que es, digamos, la principal y que nos ayuda a integrarnos mucho, al igual que Renata, en Guatemala, Bolivia y Colombia. Está enfocado en comprender y abordar las enfermedades, las crónicas y salud mental en las poblaciones, viendo que cada vez se confunde más esto. Las crónicas van de la mano de enfermedad mental o de problemas mentales y esto es bien importante en cuanto a lo que se está viendo epidemiológicamente. Segundo, trata de comprender e incorporar recursos culturales existentes. No venimos a imponer cosas, sino a salir de lo que existe allá en cultura y con metodologías participativas y enfoques culturalmente adaptados, que esto es muy importante. En tercera instancia, se construye un ecosistema en el cual se combina el aprendizaje, la investigación y la toma de decisiones para informar y ayudar a fortalecer entre uno y otro. Y en cuarto lugar, el modelo está integrado y combina investigación, y combina fortalecimiento de capacidades técnicas y de aprendizaje, y la participación comunitaria, el MEL, que es el monitoreo, evaluación y aprendizaje, para incidir en política pública. La siguiente diapositiva, por favor. Esto es básicamente lo que hemos alcanzado hasta ahora. Hay alrededor de 100 investigadores que están allí en diferentes sitios, incluyendo los estudiantes, el staff y todo. Hay 100 personas. Hay 39 hospitales y centros de nivel primario que han sido incorporados en los diferentes países para hacer la investigación. Hay 39 personas hoy en día formadas o en formación, 7 en PhD, hay 31 en máster y 1 en especialización de inteligencia artificial. Algunos están en salud pública, en epidemiología clínica, en bioestadística, y la idea es formar suficiente grupo de capacidad técnica tanto en Bolivia como en Guatemala y fortalecer la de Colombia para ayudar a instruir y mantener esto a largo plazo. Hay un monitoreo y el mentorship que es muy importante, y se han hecho alrededor de 500 reuniones de aprendizaje. Semanalmente hay una reunión. Hemos sido muy sistemáticos en hacerlo y creo que eso ha sido un gran valor. Y hoy en día empezamos con un piloto para ver qué había, ya Vicky les explica, y se iniciaron 2 grandes experimentos clínicos, uno con Dialogue y otro con Bond, que en Colombia íbamos un poquito más avanzados, hicimos otra parte y vamos a empezar una intervención multifamiliar. Esto culturalmente es muy importante en los países de Latinoamérica, donde la familia es muy, muy importante. Entonces, le voy a dar la palabra a Vicky para continuar. Vicky, please.
So I'm not going to speak in Spanish. I'm not going to subject you to that. My Spanglish is improving, but I'll do this bit in English. I'm going to focus on the impact side and where we are now. So what does our evidence show so far? So this is a combination of the research that we've done, thinking not only about the formal studies, but also about the whole process, the building of the centre, the infrastructure and the structures that we're leaving in place. So we know that trust has to drive that impact. If you don't have the community's trust, it's not going to go anywhere. So we spent a lot of time working with our communities to build that trust. Capacity building not only has the potential to increase the skills of individual researchers, it is through capacity building that we can actually change academia. In Latin America, many of the countries that we work with, there isn't a traditional pathway for researchers. So that's something that we're building. Rather than seeing research on the side and not part of your job, we're trying to make it so research is an integral part of the university's business. We also find what's missing. So we know that a lot of the health systems lack formal data. They lack recording systems. So in order to be able to show impact, we need to show where we start from as well. So we've been building that baseline level and helping put systems within the community so that we can monitor our impact. And all through this, the culture is essential. So working with the community, it should be taking the... Once have I been told that I'm not loud enough in my life? So this is a new experience. So cultural adaptation is essential. It's essential to get the community on board, but it's essential to make sure that what we leave behind fits the context. It's not about just dropping in an intervention. It's about generally working with the aims, the priorities, and the needs of the community. And we hope that the community voice shines through in everything we do. And we're continuously learning, not just within the community, but ourselves. And silence is also evidence, so it's listening to what's not being said as well as what is being said in our formal research. So, it got technical, got that touch screen. So, what's actually shifted? So, we've put structures in place. I'm not going to read all these out. You can read these, and we're obviously welcome to share the slides. But we've put structures in place. But it's about not just doing individual projects, but coming together as a centre, having that shared identity. And we have now people, about 70 people, including our early career researchers, working specifically on implementation. It's about real-world impact, actually changing the health outcomes of our communities, not just academic papers or an academic exercise. It's actually seeing that change. And to see that change, it has to be led and owned by the community, not by the researchers. This is the community's project. And it's about behavioural change too. I'm just going to leave you, for your own time before we introduce the next speakers, just a few quotes from some of our individuals in the community that see, if we can go on to the next slide, please. If we see the real impact that we're having. So there's lots of different ways that we can measure impact. And we do this by looking at the system, by looking at the universities, but importantly, we do this by measuring the impact on the community health system, particularly on our indigenous communities, as Carlos mentioned, but also on our individual researchers as well. And it's been a great journey so far.
Muchas gracias. 7 minutes.
Okay, can we kindly welcome the next center? That's the Center for Global Health Research for Multiple Long-Term Conditions. Kindly with a round of applause. So this time we'll look at the 5 minutes very well. Yeah.
Good morning. Yeah. So this presentation is on behalf of Kamlesh Kunti. As you know, he's a very shy guy. He doesn't want to come here. So you can raise your hand. So Kamlesh Kunti and all the other members of our group were sitting on the corner tables. Please raise your hand. Yeah. Thank you. Can we go to the first slide? I can't see the slides. Oh, I can use that. So I'm going to make a brief presentation, maybe 5 minutes. Can I have the slides, please? Yeah. Next slide. So I won't dwell in this too much. You can, as you can see, it's multiple institutions, a multidisciplinary team, and a large team that's involved in this project. Next. So, as we said, we plan to do 3 things. Number 1 is research capacity strengthening, and community engagement. And what we wanted to do was an integrated technology-enabled, large, transformative healthcare reimagination for treating multiple long-term conditions. Next. So we had 3 aims: the short-term aims, the medium-term aims, and the long-term aims. I'm pleased to say that we have completed all the short-term aims that we had said that we would do in the first 1.5 years or so. And we are in the process of completing the second medium-term aims, and the long-term outcomes is to establish global center, and we are on the path of doing that, and I'll give you some examples of how we are doing that. Next. In terms of the intervention itself, we decided that we will develop an electronic decision support system for the management of multiple long-term conditions using years of our experience working in the development of this computerized decision support system for various non-communicable diseases, and we are trying to put it all together, and we are almost underway in terms of, it will be completed within the next few days. The pilot is ongoing. We will complete it in the next few days and start the trial. We also have an interoperable assisted telemedicine platform which has several innovations incorporated into it, and we are using it currently. We'll be using it by the end of the year in 100 locations in the country, and this will be main component of this particular research program. The third is we are developing patient-facing application and a decision support for training community coordinators and community champions. Close to 200 of them will be trained across the country. And the next slide. And the research itself comprises of a cluster randomized trial in 104 primary care centers in India and Nepal, where one group, the intervention group, will have a community champion and a care coordinator empowered with the electronic decision support, who would be providing care for multiple long-term conditions against the usual care. So this is the research that we are planning. In terms of research capacity strengthening, we promised that we will train around 45 to 50 postdocs, masters, and PhD students. And as you can see here, we already selected 8 master's candidates, 12 PhD candidates, and 13 postdocs who have or were in the process of completing their training. In terms of institutional capacity building, we promised that we will train and introduce the concepts of various areas of NCDs to 400 researchers across the country, and we have completed training 300 of them through 6 workshops. There are 2 more workshops left, and we will do that. And the topics that have been included include quantitative health research methods and biostatistics, health data science and economic evaluation, qualitative research in public health, implementation science, and grant writing training course. And we are also planning a webinar series. We also would like to put it out as a service to the community, except for the qualitative research methods in public health, where we don't have the permission of the developers. In using that, we want to create a platform where everybody can access these training programs and use it across the board, across the world. In terms of the environmental capacity building, we have provided we'll be providing healthcare provider training, secondment training for research support staff, and collaboration with various government institutions, including the Indian Council for Medical Research, where we provide training through our platform in terms of multiple long-term conditions, and various branches of the Indian Council of Medical Research, the National Human Health Resources Center, and we also had discussions with institutional heads across India who influence policy. Okay, next. There have been several publications in very high-profile journals. We have published 17 publications, including Lancet and the BMJ. 7 are under review. When I mean under review, there are 4 or 5 of them have been accepted for publication, and 4 are in advanced draft stage. Next. In terms of policy relevance, we are putting the patient at the center of healthcare and addressing the burden of multiple long-term conditions through an integrated approach. It's in alignment with the universal health coverage policy and is shifting towards a person-centered and sustainable health system strengthening. We are co-designing a contextually relevant care model to advance continuity of care by involving multiple stakeholders, communities, and every other person possible. And we are leveraging digital health, as I said earlier, building national research capacity to address MLTCs, advocacy for the Emerging Leaders Program. This is an important program by the World Heart Federation, which is an international program. And this December, we are having a program to train 25 emerging leaders across the world. And this is based on Kamlesh's and my advocacy with the World Heart Federation. And this is the theme for this year. We have conducted national symposium to identify research priorities and advance policy on healthy aging, which was completed recently, and had several stakeholders from the country as well as from UK. Next. So to summarize, this is what we are doing. We have understood the growing burden and the system gaps, identified the gaps. We have identified the common disease cluster. We have integrated the interventions, and we are transitioning to full randomized controlled trial, and we are working towards providing patient-centered care. Next. I think this is the last slide, so these are some glimpses from the field. Next. Yeah. Thank you in all the languages.
Thank you very much. Okay, can we have the next center? Mental health and physical together. Okay. Thank you. Would you like to use the slide?
Yeah.
Assalamu alaikum and good morning. I'm presenting on behalf of Center for Impact, Center for Improving Mental and Physical Health Together. And our team is sitting over there. Next, please. So our center is operating in Afghanistan and Pakistan. And you may know that Afghanistan and Pakistan and the region is one of the post-conflict or always in conflict areas with fragmented systems. And generally when we are handling or tackling global health crisis, we mainly focus on diseases, and sometimes we forget the environment and when those, in which those diseases take place. So in Center for Impact, and I'm sure in all other GHLC centers, our main mission is to look to those systems and the community factors and address the conditions. Our main focus in Center for Impact is on developing, evaluating intervention at the primary healthcare level and community level. And we are focusing on three main conditions, on hypertension and cardiovascular diseases, on diabetes and mental health disorders, specifically on depression. Likewise, we model and evaluate population level interventions on tobacco, sugar-sweetened beverages and physical health. And of course, we have very focused attention to capacity strengthening at multiple levels and promoting gender equity and inclusive research. Next, please. Next, please. Our research focus in Center for Impact under the cardiovascular disease is on hypertension management in rural areas delivered through community health workers, and it's targeting around 3,400 participants. And in diabetes, in Afghanistan and Pakistan for the prevention of diabetes through 12,000 participants, and utilizing the participatory learning approach, intervention is delivered through 144 community groups. Likewise, in mental health, in Afghanistan and Pakistan, we are focusing on two main intervention: problem management plus a WHO package, low scale package, and collaborative care. And PM Plus is implemented for the first time with this large scale in Afghanistan. It has been previously implemented in several countries, including some African countries, but with this large scale, it is implemented for the first time in Afghanistan. And at the population level, we have multiple activities, including a first national survey on sugar-sweetened beverages in Pakistan. Next, please. I'll go to the next slide. I will come back to this. Next, please. So I will also talk about Afghanistan specifically because Afghanistan is one of the post-conflict areas with a lot of challenges. So in Afghanistan, we are implementing diabetes and mental health. In diabetes, we are implementing the PLA-based participatory learning in action-based EmpowerD. It is a feasibility study. So the definitive trial is taking place in Pakistan. In Afghanistan, we have feasibility study. So despite all those challenges for community participation, involvement of females, we have been able to recruit 256 participants with 50% of females. And in the PM Plus, the intervention focusing on mental health, We have been able to include 700 community health workers along with community health supervisors in 5 provinces, and we have been able to develop the theory of change, establish community advisory panels, and lately we have established a community collaborative, although it's a very challenging thing to do in Afghanistan, but we have been able to establish the community collaborative. Although we do not call it, community coalition, we call it collaborative because the coalition brings some political sensitivities. Please go back to the previous one. So one of the main focus areas or integral part of our work is capacity development. It happens at individual level, institutional level, and system level. So we have PhD programs, masters, and certificate programs. We have collaborative PGs across centers. We have mentorship scheme. And we are working with national MOPH and other institutions to build their capacity in research. Next slide. So of course, we have a lot of challenges. It ranges from mobility restrictions, barriers on travel or visas, especially for Afghanistan, staff retention issues, limited or fragmented data systems, and complex policy environments. What we have learned is that there is need for flexible implementation strategies, which we have been doing in Afghanistan and Pakistan, and incorporating the views and meaningfully engaging community in all the approaches, and most importantly, focusing on capacity strengthening of the institutions and individuals involved. Thank you.
Thank you very much.
Thanks. Can I have my slides up, please? Yeah, that should be the one. So, good morning, everyone. I know we have been given 5 minutes, but for those of you who have been to India, you know that timelines and traffic lights are just suggestive. You know, so, but I'll do my best to finish in 5 minutes anyway. So, look, I'm here on behalf of my colleagues from Imperial College London. My co-principal investigator, Professor Chris Millett, is not able to be here, but also from George Institute and Manchester, University of Manchester, Srihar in Chennai, and University of Brawijaya in Indonesia, and ICDDRB in Bangladesh. The colleagues from ICDDRB are still on their way. So can I request you to please stand and please be acknowledged. You do all the work, and as I was telling Tolib that as investigators we take all the credit. So that's the way life works anyway. So let's go to the next slide, please. So for those of you who have been to previous meetings of these past consortia, you'll know that we love this this particular picture. We show this every time because this tells you all about our center. Our center is all about research excellence, community engagement and involvement, research capacity strengthening, with the overall goal to become a recognized center of excellence on NCDs and global environment change in LMICs. I think we all recognize the importance of global environment change. We are living through one almost on a daily basis. This year, India is supposed to become perhaps hotter than it has ever been. We have our focus in 3 countries, India, Indonesia, and Bangladesh, with 3 different environment-related problems which all impact non-communicable diseases. Next slide, please. So we have 3 themes in our project. The first theme is to integrate all our interventions in the primary healthcare system. And in the primary healthcare system, we are also, like the multiple long-term condition group, using technology platform which we'll call Smart Health Platform. This is a platform developed by the George Institute for a long time now. And the focus has traditionally been on targeting cardiovascular disease, COPD, diabetes, and chronic kidney disease. But now we are expanding the scope, and the innovation there is to integrate a novel heat health risk assessment module, early warning adults or frontline health workers, and similar for air pollution and water salinity in different countries. Next slide. There is a multi-sectoral focus, which is the theme 2, and the multi-sectoral focus is in collaboration with all the stakeholders, including communities, and the multi-sectoral focus is different in different countries. You can see in Bangladesh, it is around mitigating coastal water salinity and strengthening cardiovascular disease, NCD services specifically. In Indonesia, Indonesia is an archipelago. We are working in East Java district, East Java province in the district of Malang, where we are working with the communities there on reducing the burden of unregulated plastic waste burning and enhancing waste management. And that is really an example of a work that kind of changed from how we had envisaged it to where we are now, simply based on community inputs and understanding of the policies locally. In India, we have our work in 2 locations, in the state of Andhra Pradesh, which is in the southeastern part of India, and in the state of Chhattisgarh, which is in the central part of India, which is around heat and around increasing dietary diversity to reduce non-communicable diseases. Next slide. Empowering people is our 3rd theme, and empowering people has these following components, again developed by our community engagement team in consultation with the communities. So the scope of work is to inform the communities through one-way communication. This is how we start, but I think we then graduated to bi-directional communication by consulting them and then involving the communities into the work that we do through participatory cooperation. Collaboration involves deep engagement with the communities and eventually transitioning to shared leadership. So all our work packages have shared community leaders involved in leading those work packages, and thereby these entities, they take ownership of the work that is being done, so that once this center itself withdraws or the researchers withdraw, there is local ownership which allows sustainability or continuity of the work locally. Next slide, please. Tailored capacity building. So in this symposium, our center is focusing on capacity strengthening, and we'll talk more about it. But our capacity strengthening is also multidimensional, starting from communities. So community health workers, who are really the backbones of delivering any intervention in countries like India or other low-income countries, but also recognizing that the environment change is a problem of the next generation. So we have to involve the youth and the children and make them as agents of change, so that they can continue taking the message around into their communities and also beyond into the coming years and decades. Policymakers are important. We have to involve them, although changing their minds is not as straightforward as we can with some of the other policymakers. And we work with civil society organizations and a number of grassroots partners who are implementation groups that have been working in those communities for decades and have established a relationship of trust and mutual understanding. Next slide, please. So this is our vision of how do we transform the paradigm from a traditional health system to climate resilient health system. And we use this, you can see the focus in the top row, and then what design do we take to make this change to happen, from a top-down researcher-led clinical mandates to a co-produced set of interventions which utilize local indigenous knowledge and shared community leadership. We are using data and technology in an intelligent manner, not to make it data and technology heavy, because that is not something which we have realized is going to solve the problem, but it should be something that enables people to do whatever they want to do in a better way. So moving on from fragmented paper records, etc., to using real-time digital platforms, and using the same platform to collect data and also to use that data to come out with interventions and implement those interventions. The scope also, we envisage that will change from clinical healthcare sector to multi-sectoral governance, integrating various sectors that are involved in this entire process, which may range from health to engineering to water management and so on. Next slide. So bridging science and policy is an important goal through targeted regional advocacy, And again, this is something which is specific to the different countries in which our project is underway. In India, the aim is to prioritize sustainable food systems, in Bangladesh to mitigate coastal salinity, and in Indonesia to regulate plastic burning. Next slide. So this is the path forward. I'm coming to the end of my presentation. So the path forward involves integrated governance, community-led co-production, and evidence-based implementation. I think the last part is important because there are a number of interventions which we think should work, but unless we generate evidence that yes, they do, they don't. And this is something we learned really in Indonesia as to the notion that we had gone in with changed as we interacted with the communities and learned what do we need to do by breaking down silos, elevating local knowledge, and then find and implement scalable solutions locally. Next slide. So this is the last slide, so thank you very much for your attention, and we're happy to take questions.
Thank you very much for your presentation. So I'd like to invite the last presentation from the Stop NCD team. So because they are the host institution, we'll give them additional 0.3 seconds. So please, with a round of applause.
Thank you. I think this one works. Thank you very much, and good morning again, and welcome, and really delighted to see teams who are becoming friends. Yes, so I'm presenting on behalf of the Stop NCD, which is co-led from the London School of Hygiene and Tropical Medicine by Professor Tolib Mezov, and from the Ghana College of Physicians and Surgeons by myself, but with participants from other countries. So if you can wave, we have Burkina Faso here, we have Niger here, we have Ashasi University here, so that's Stop NCD. The next slide, please. And we've used this map to kind of tell you a bit about ourselves, because apart from the research team in all the 3 countries, we have engaged stakeholders very closely. The Ministry of Health, and in Ghana, because the Ministry of Health has an agency model, our engagement has been with the key provider agencies, the Ghana Health Service, the Christian Health Association of Ghana, and then with the National Health Insurance Authority. And I'm delighted that I can see our partners in this room. So thank you so much for coming. And then in Burkina Faso, in Ghana also, we have a Ghana NCD Alliance Ghana. So they are a partner on the work, and I think they are somewhere in this room. And then in Burkina Faso and Niger, there's also an NCD Alliance Niger. So they are their partner there. In Burkina Faso, there's no NCD Alliance, but multiple CSOs. So they have engaged about 2 or 3 key CSOs, as you can see there. Next slide, please. Since we were given only 2 seconds, I will not, please, the next slide. Yes, our goal. Yes, and the goal is to, like all the other centers, and in fact, it's been very interesting listening even to the 5-minute presentations. Number one, I was struck by the fact that the idea of time in Ghana is very similar to the idea of time in Latin America and in Asia. People will tell you, I'll be there at 6:37. You know, so that your mind is tuned to the fact that you must be flexible. Okay, I'll try not to stress you with Ghanaian flexibility and stay within 5-6 minutes. Okay. So our goal is to contribute to improved health of West African populations through comprehensive and sustainable capacity strengthening for high-quality applied NCD research to improve prevention, diagnosis, and management. And we focus on hypertension, diabetes, and common mental health conditions, but we keep telling our partners that if we find the way to make this work, it can be extended beyond these. Next slide, please. Okay, and our ambition is not to end in 2027 and put a full stop, and I think that's the ambition of all the centers, but rather to leave a legacy of person-centered, integrated, system-wide responses to conditions that are very much interconnected and that really require engagement at the community and primary care levels. And then within West Africa, African-led research by high-caliber scholars embedded within supportive institutions, networks, and policy environments to all contribute to this goal of improvement in NCD-related morbidity and mortality. Next slide, please. And I think like the other centers, our objectives have moved in a progression. We started with context analysis in year 1, spilling over into year 2 to try and understand what is going on, what do we do. And then in year 2, spilling over into year 3, we started co-producing interventions with stakeholders. So the interventions we've come out with in all 3 contexts are very much led and owned by the stakeholders and not just by the research community. And then there's always been that tension between when you, in fact yesterday, NIHR brought it out very nicely, that when you start co-producing, you co-produce the ideal. Then you need to go back to people and say, we agree, but in the real world, what can be practically done? Then we are now in the stage of implementing and evaluating interventions, and I'll just touch on what is being implemented and evaluated in each context. Then cutting across these 3 very research activities has been capacity strengthening, research uptake, community engagement and involvement, and establishing and maintaining equitable partnerships, similar to our colleagues in the other centers. Next slide, please. So briefly, the interventions across the 3 contexts, and we are working in coastal West Africa, represented by Ghana. And West Africa is largely Anglophone, Francophone in terms of official language. There are multiple indigenous languages, and basically most of these indigenous languages are being protected. And part of the protection is that if you have about 20, 30 indigenous languages, there is a usefulness in having an official language which doesn't belong to any of the groups, because then we don't fight over who is trying to dominate who. We just get on with it. So you have the English, the French, and then the Lusophone. There are some Portuguese-speaking countries. So across and then you have the coastal West Africa, which is Ghana, where we are. Then you have Sahelian West Africa. So 2 of our countries, Niger and Burkina, are located in the Sahel of West Africa. But there are commonalities across the context. So our interventions have these commonalities. They are all complex and multifaceted. In fact, one of the things we found in our context analysis is that there's a lot of evidence, but the evidence is about unitary interventions, and that issues are systems. So we ended up trying to pull the evidence into more systems interventions, people-centered, and then embedding in primary healthcare systems at community and sub-district level and enabling higher level referral, and then peer support networks. In all the 3 contexts, we are trying to see how can you make peer support networks work and increase adherence, support, engagement. And then there are contrasts with cross-learning potentials. In Burkina Faso, they are additionally working on registries of diagnosed clients to try and have a continuous record. In Niger, they are experimenting with telemedicine to see if you can still get services to very remote areas, sometimes with insecurity, some other way. And then in Ghana, as part of the engagement, we've actually introduced a community screening module for NCD into what is called the e-tracker, which is used by the health system. And then there are colleagues from Ashasi have innovated with the NCD NutriBot. I think there's a lot on their poster. You can learn more about it. But we realized that there was a big problem with nutritional advice. And in a country where you have 1 nutritionist per It's almost 700,000 people. There's no point telling somebody go see the dietitian to advise you on how to eat. So that is trying to deal with that. And then there's also the engagement with the Community Health Planning and Services and the National Health Insurance Scheme, and responding to Ghana's current free primary health care policy window to try and generate evidence that will help the country in the decision making and implementation. And we are pleased to say that because of the engagement, we hope, we think it is helping. Okay, the next and the last slide. Yes, thank you so much from all of us.
Thank you very much. I think we kind of did a good job with the timing, so congratulations. And it's really amazing to see the heart and the passion behind all the work that we are doing. So next on the agenda, before we go on a little break, we have some brief messages from some key intervention implementation partners that we work with in Ghana. So it is my greatest honor to welcome Dr. Samuel Kaba Akoria, the Director General of the Ghana Health Service. He's a consultant neurosurgeon, and okay, he says I shouldn't read all that.
No need. Hello, good morning, everybody. I think I'm very privileged this morning to be here and see this whole issue of One Health approach to our health system, and see that in many countries, the way to go has to do with the primary health care. And as one of the biggest stakeholders in implementing the primary health care in Ghana, which was launched, I think this is an eye-opener. And I would like to really take the opportunity to say thank you so very much to all those who presented. Now, Madam Chairwoman, with your kind permission, I would like to recognize the established protocols and proceed with this solidarity message. On behalf of the Ghana Health Service, I express my profound gratitude and appreciation to the leadership of the Ghana College of Physicians and Surgeons and the Stop NCD project for inviting the service to be part of this important symposium. We have come too far. We have seen so much, but yet more to do. History has it that countries that invest in research and use the outcome in decision-making are countries in continuous development. Based on internationally comparable estimates, using purchasing power parity, the United States reached $806 billion in gross domestic expenditure in R&D in 2021, followed by China, the second highest, and other countries like Japan, Germany, South Korea, and United Kingdom, and of course, France. We all even know that quite recently, a rocket was launched onto the moon for exploratory purpose. And sometimes I do remember I say to myself, can you imagine if Ghana had discovered the COVID vaccine? What would that mean to our economy? Anyway, we are not only prioritizing research in Ghana, in Ghana Health Service. We have 3 research centers within the Ghana Health Service, and we plan to expand and establish new research centers. In Ghana, NCDs are silent killers. Their rise represent not only a growing public health challenge, but also a strain on our already limited healthcare resources and required immediate specialized care and partnership to improve outcomes. That's why this symposium is very important, because discussion, among others, on NCD aligns directly with the objectives of the Free Primary Healthcare Initiative and the Ghana Medical Trust Fund, which is Mahama Care, which is for NCDs. The free primary health care, which have been recently launched, is primarily focused on disease prevention and screening for non-communicable diseases, and we need strong partnership for its successful implementation. Locally, the outcome of research is already influencing our preparedness towards the implementation of the free primary health care. Some preliminary results from our Kintampo Research Center on hypertension showed that 45% of the people above 40 years of age were hypertensive. 60% of them did not know of their status, and 45% of them, of course, were not on medication. This, in part, explains the numerous strokes and the burden on our health system. But this also provides an idea and a baseline of what to expect, resources and strategies to deploy in the implementation of the free primary health care. So, Kintampo Research Center, thank you so very much for highlighting on this. Additionally, Madam Chair, the Ghana Health Service, in line with our strategic partnership, have been involved in the co-production of the NCD CareNet intervention as part of the work of the National Institute for Healthcare and Care Research Global Health Research Center for NCD control in West Africa. Stop NCD. I think the previous speaker did mention. These life-saving interventions, which are being piloted in 3 of our districts, Gansaf, Shai Osudoku, and Kwahu Afram Plains North, involve screening for body mass index, blood pressure, fasting blood sugar, mental health status at the primary health care level facilities, CHIPS compounds, health centers, and maternity homes, alongside with health education, promotion, nutritional, and other counseling services. It is therefore my hope that at the end of the 3-day symposium, together, we would deliberate, share ideas, discuss innovative solutions, and commit to actions that will transform as well as reshape our sustainability strategies. May the time you spend here in Accra be filled with enlightening conversations around how we can sustain these global health research centers, valuable networking and opportunities with colleagues, and renew commitment towards ensuring ownership and sustainability. And I'm so happy to see all the presentation talking about community involvement and ownership and sustainability. As I usually say, in the life of every generation, the spirit of togetherness must come true and true if we want to make our mark in history and save humanity. Investing in research is not a luxury, but a must-do and a gateway to healthy population and development. On this note, for those who are new to Ghana, I want to add my voice to welcome you, but also encourage you to buy souvenirs from Ghana. Buy Ghana, build Ghana. We appreciate that. It is my pleasure being with you this morning and wish you all a fruitful discussion and a successful symposium. Thank you, everybody, and God bless us.
Thank you very much, DG. I would like to invite the Deputy Executive Director of Christian Health Association of Ghana to also give his remarks. Kindly welcome him with a round of applause.
Prof. Chair, Director of the Ghana College of Physicians and Surgeons, I see the advisor to the minister here in the room. Colleagues, senior colleagues from Ghana Health Service, Ministry of Health, NIHR, FCDO, distinguished ladies and gentlemen. I think if I stand on the existing protocols, I'll add a little bit height to my height. So our executive director was supposed to be here, but he couldn't make it, so he asked me to be here to join you in this symposium. As the Director General said, I think it's not a mere coincidence that today we have partners from all over many countries and researchers around talking about NCDs at such a time when we have just launched the free primary healthcare and are about to implement. As CHAG, we are proud, and thank you very much, Prof. Irene, for including some of our facilities on this important research in some of the remote places in Donkokrom and others. It adds to our focus on NCDs for the past few years, and I'm happy to highlight that some of the interventions that we have done highlight how faith-based institutions are contributing to the NCD front. At the moment, we are working with National Health Insurance on value-based care for non-communicable diseases. If you look at the data, you'll find that there are so many people who are actually engaged in the health system. But if you look at the number of people who attain control, it's so limited. So the question is, what is happening? I guess it's not access. It's about quality of the care that we provide, which is what we are currently doing with NIHR. Not to really look at volumes of people that we are seeing, but of the numbers that are actively engaged in the health system. Are they attaining control? So far, we've done this work for the past 2 years. I think we are yielding a lot of results, and we'll be showing very soon. A few years ago, with huge numbers of community health nurses, we decided to deploy them to rural communities to screen. We were so surprised about the numbers. We were able to identify 76,000 people from rural areas, contrary to our thought that NCDs are predominant in the cities. And all these people have been connected to the health system. Through telecounseling and logistical support that we added to this work, we have been able to strengthen community trust. I'm happy that one of the centers highlighted on trust. Trust, accountability, and embedded ethical, patient-centered practices in everyday care. It was based on this that WHO is currently supporting us to expand community screening. Now, while we celebrate all these achievements, we must confront some of the policy practice mismatches that we have. If you look at the Ghana NCD policy, it says that prevention is key. But unfortunately, if you go out and do preventive care, it's not reimbursed. So the policy focuses on that, but in practice, we don't speak to what it is. I remember the phrase site-specific accreditation, which NIHR is always saying. It's an issue. Now, if we'll be able to address NCDs collectively, then some of these disconnects must be addressed. We commend the government of Ghana for the bold step of introducing the free primary healthcare policy. And we also thank the government for the preparation so far for its implementation. I believe that with the introduction of this policy, preventive care will no longer be sidelined, but it will be fully integrated in our continuum of care. Equally, we also celebrate the Ghana College and all the members that are part of the Ghana team for this research. Your contributions exemplify the power of local expertise in shaping global solutions, and we are proud that Ghana's voice can be heard everywhere now. Finally, as we strengthen our collective response to NCDs, we call for standardization. I wish the Ghana Standards Board is here. Sometimes when I look at the numbers, I feel our BP machines, glucometers. I don't know how we are standardizing them. Some of the numbers we may be either over-reporting or under-reporting. I think that as part of this research, it will be good to look at standardization as well. We are so happy, and thank you, Prof, for inviting us. We live here with renewed commitment to do what we do in our villages. We look forward as CHAG to receiving some of the evidence that is coming from the other centers, hoping that they will contribute to transforming the future of NCD in Ghana. Thank you very much.
Okay, so we're about to have a little break. I think you heard a little bit of what is about to come. We'd first of all like to acknowledge the presence of the National Health Insurance Authority. Thank you for being here with us. If you could give us a little wave. All right. So what you're about to see next is a celebration of our culture and our tradition. It's not just a performance. It's going to be something you've never seen before. So we've been sitting for a while. So as they come in, feel free to get up and let's see a bit of those dance moves from the various countries we represent. Enjoy this break. Thank you. I hope you had a lovely time, and a big ups to the LATAM team. They brought the energy. And thank you all for participating and for being a part of this. So that's just a little bit of the Ghanaian culture. So that's a cultural dance from the northern part of Ghana. And interestingly, they use it for community celebrations. I thought you might be interested to know that since you are involved in community engagement.
Okay, so we are moving to the next session of the program. We'll be having a keynote address by the Minister for Health, but he's being represented here by the Director for Technical Coordination. That's in the person of Dr. Hafiz Adam. So Dr. Hafiz Adam is a Ghanaian public servant working with the Ministry of Health, where he serves as the Director for Technical Coordination. In this role, he helps support the coordination of technical and operational aspects of health programs and policies across the country. He works with different departments and agencies within the health sector to help ensure that national health initiatives are effectively planned and implemented. His works involved contributing to the smooth implementation of health strategies, thus supporting the collaborations between institutions and assisting in the alignment of technical efforts within the ministry's overall goal of improving healthcare delivery. He spent several years in the Ghana's Public Health Service, and he is currently taking roles that are focusing on administration, coordination, and supporting government's efforts to improve healthcare. With a round of applause, can we kindly welcome him?
Thank you very much. Prof. Chair, Director of the Ghana College of Physicians and Surgeons, Professor Adeno, Dr. Kwekwa, the Technical Advisor to the Honorable Minister of Health, the Director General of Ghana Health Service, who was here a while, representative of Foreign Commonwealth and Development Office in Ghana, Prof. Kara Hansen, Director of the NIHR Global Health Research Program and representative of NIHR UK, distinguished representative from NIHR Global Health Research Centers across Africa, Asia, Latin America, and UK, Ghana, civil society representation, members of the media, distinguished guests, colleagues, directors, and staff from the ministry and other agencies, ladies and gentlemen, good morning. Oh, should I inform the minister that you didn't respond to his greeting? I bring you warm greetings from the Honorable Minister, Honorable Kwabena Minta Kando, who is the Minister for Health of Ghana. Unfortunately, he is unable to be here personally, but considering the importance of this gathering, he's asked me to come and represent him. So my job is simple, two things. The first thing is to express his regrets for not being here because it has conflicted with other equally important occasions where he has to be. And the second thing is to inflict on you a 6-page keynote address. In fact, he's lenient. The last time I read or I went to represent him, it was 14-page keynote address. And so this time, I'm sure he considered that you are coming from far. UK, you are coming from India, Pakistan, and all of us. So I think he's lenient because of the distance. And so, distinguished guests, it is my honor and privilege to address you on this important global gathering. I send warm greetings on behalf of the government of Ghana and the Ministry of Health and commend the organizers for convening this timely symposium under such a critical theme. Across West Africa, including Ghana, our health systems are undergoing a significant epidemiological transition. We now face a double burden disease where the rising prevalence of non-communicable diseases such as hypertension and diabetes coexist with persistent communicable diseases and maternal and child health challenges. Distinguished ladies and gentlemen, the effective management of NCD depends fundamentally on the strength of our primary healthcare system. A resilient primary healthcare system enables early detection, continuous management, and prevention of complication, reducing pressure on tertiary facilities and improving health concerns. Prof. Chair, distinguished guests, a strong primary healthcare response to NCDs must rest on 3 pillars: community engagement to promote healthy lifestyles, routine screening and early diagnosis, and reliable access to essential medicine and long-term care at the community level. Research plays a pivotal role in this effort. It allows us to identify interventions that are not only clinically effective, but also sustainable, affordable, and dependable to local connections. Evidence generated within our settings is essential for informed decision-making and impactful policy design. Ladies and gentlemen, the support from NIHR and the UK government is both timely and invaluable amidst the rising burden of non-communicable diseases in Ghana and prioritizing of system-wide approach and universal health coverage. We therefore consider it privilege and honor that one of the 5 Global Health Research Centers awards by the UK National Institution of Health Research and Development of Social Care in 2022 in West Africa, and co-hosted by Ghana College of Physicians and Surgeons in Ghana, and LSHTM in the UK with Associate University in Ghana, in Niger, and Catholic University of West Africa in Bobo de la Soul, Burkina Faso, as a member of the research consortium. We are delighted that the 3rd Cross Centers Global Health Symposium of these 5 global research centers is being held and hosted in Ghana, after hosting of the first in Dhaka, Bangladesh in 2024, and second in Leicester, UK in 2025. Strengthening Ghana's primary healthcare system, attaining universal health coverage, and making sure that NCD prevention and care are integrated into all the efforts that are prioritized by government of Ghana. This reflected in the policy priority we are given to the development of policies and programs and their implementation for universal primary healthcare services. At the base and foundation of our district health system, the community-based health planning and service, popularly known as CHIPS, through sub-district level. Similarly, the priority given to ensuring community of care is reflected in Ghana. Again, the priority given ensuring continuity of care is reflected in Ghana Trust Fund, popularly known as Mahama Cares, that has been established to help with domestic fund raising for higher level referral care for non-communicable diseases. Distinguished ladies and gentlemen, the launch of the start of phase implementation of free primary health care policy by His Excellency John Dramani Mahama, President of Ghana, on the 15th at Sai Osudoko District, marks the commencement of the phase implementation of national sector and setup. Non-communicable disease education, screening and referral are part of the package, as well as information technology system to tracking and community of care using the e-tracker from community level screening upwards. We are pleased that the research being supported by UK NIHR through Stop NCD has contributed enormously to informing remains committed to informing relevant aspects of these important national efforts. Staff of the Ministry of Health and its implementation agencies such as Ghana Health Services, Christian Health Association of Ghana, and the National Health Insurance have effectively participated in the stakeholder forums and co-creation process for designing of the Stop NCD intervention, as well as the implementation, and continue to do so, ensuring that design is not abstract,
or theoretical, but responsive to the needs of information for decision making and implementation on the ground. Distinguished guests, this co-creation approach ensures that the research is relevant and belongs to the health sector in Ghana as a whole. We once again extend our warm welcome to our international participants from 5 NIHR Global Health Research, NIHR Global Health Research Center for Community Management of Long-Term Conditions in Latin America, NIHR Global Health Research Center for Multiple Long-Term Conditions in Southeast Asia, NIHR Global Health Research Center for Improving Mental and Physical Health Together in Southeast Asia, NIHR Global Health Research Center for Non-Communicable Diseases and Environmental Change in Southeast Asia, and the NIHR Global Health Research Center for NCD Control here in West Africa. Prof. Chair, distinguished guests, we thank the UK NIHR and FCDO for their continuous commitment to intervention and investing in global health research in developing countries that are eligible to receive official development assistance from the UK International Development Budget, and their emphasis on equitable partnership between research and institutions in low and middle income countries in the UK. It is my hope that beyond the conference, you will experience the warm culture and hospitality of Ghana. As I conclude, distinguished ladies and gentlemen, let us reaffirm our shared commitment to advancing research that is impactful, inclusive, and responsive to the realities of the population we serve. Together, we can build a stronger health system and ensure a healthier future for all. Thank you. May God bless us all, and thank you for your attention.
Thank you very much. So now we'll go on a very short break to have some snacks. So to my left, there's a setup, so you can just go there. We have about 10 minutes, so you can stretch your legs, take a few snacks, and then we'll come back to end the ceremony. Thank you. Okay, so sorry. We are almost to the end of the program, so there's a suggestion that we should just end it, and then we can go and take the snacks. So we'll just go on to the next line on the program. Sorry about that. We'll end very, very soon, and then we can go and take the snacks. Okay.
Okay, so we would like to get some closing remarks from the chairperson. Yes. Kindly welcome him. Thank you.
Well, it's good morning again, ladies and gentlemen. I think we've heard a lot. If I want to summarize, it will take another 1 week. But we've heard it all. Beautiful talks, especially about non-communicable diseases involving the community, the vulnerable, the low-income group, the middle-income group, innovative changes that we've heard from so many places. So I think at the end of the day, if the challenges are improved, we can visit those countries, we encourage them. One thing I heard, which I want to appeal to my co-chair and the organizers, is that the program cannot end in 2 years. in 3 years. It should be continuous so that we will appeal to you to have more funding for research, and research is a pivot of any development. Thank you so much. Let me now close this part of the section for you to stretch. I hope you've drank your water and you are now going to move your limbs. Thank you very much, gentlemen.
Thank you very much, Mr. Chair. I would like to invite a representative from Ashesi to give us the vote of thanks. Okay. Williams. Yeah, William.
All right. Honored guests and representatives, distinguished officials from partner institutions, colleagues, all protocols observed. On behalf of the NIHR Global Health Research Center for Non-Communicable Disease Control in West Africa, STOP NCD, I would like to sincerely thank you all for a rich and engaging first day. We are especially grateful to our co-chairs, keynote speakers, representatives from the Ministry of Health, Ghana Health Service, CHAG, NHIA, and center representatives for their insightful contributions. Today's discussions have reminded us that our work must extend beyond knowledge creation to strengthening capacity, particularly our ability to inform and shape policy. We have also been challenged to reflect critically. While prevention remains essential, it is clear that prevention alone is not sufficient in practice. There is the need for interventions that are not only clinically relevant, but also contextual and accessible and affordable within our health systems. We deeply appreciate the contributions from our government and implementation partners for grounding these conversations in real policy priorities and lived realities. To all participants, thank you for your active engagement and commitment to advancing sustainable and impactful global health research. We look forward to continuing these important conversations in the days ahead. Thank you and have a pleasant rest of the day.
Thank you very much, William. Okay, so we've come to the end of the program. We are very grateful for your attention. In fact, we're researchers turned MCs, so we hope that we did something better. Great. So we are going to take a picture, a group picture. I think the technical team will direct us to where we will take the picture together. Then after, we can take our snacks and then lunch. Thank you very much. Thank you.
Thank you.
One last round of applause. Hello, please, can I have your attention? Please, it looks like I gave some half information. So after, the centers would have to stay after lunch. So if you are not part of the centers after lunch, you can go. But currently, the picture is outside. We are still, it's outside. Yeah. So please, we are currently taking the picture now.